Hi everybody, welcome to Dr Manny's YouTube Learnshops. This is part 6 where we review potential complications that are related to veno-venous ECMO, extracorporeal membrane oxygenation. Now, the learning objectives for this session are to review the potential patient-related complications that could occur during V-V ECMO and system-related complications that could occur during V-V ECMO. Now, patient-related complications include hemorrhage. And hemorrhage could occur from cannula site, the surgical site, as a result of hemolysis, thrombocytopenia, disseminated intravascular coagulation coagulopathies, and gastrointestinal problems. The management is primarily, if it's bleeding, digital pressure, hemostatic agents like aminocaproic acid, aprocitentan, blood products such as packed red blood cells, fresh frozen plasma, platelets, cryoprecipitate. Or make sure that you've got heparin monitoring through activated clotting times or activated partial prothrombin times, thromboplastin times. Also, you could consider an antidote such as protamine sulfate 1%. Another potential problem is thrombogenesis. And it's probably the most common mechanical problem despite anticoagulation and heparin-impregnated circuits. And this could lead to oxygenator failure or consumptive coagulopathies such as DIC. The management is always to monitor circuit closely, do an APTT or an ACT if heparin is being administered. And typically, the ACT should be between 180 and 220 seconds. Use impregnated cannulas and circuits. If there are any small clots identified, aspirate them, because this can activate thrombogenesis. Change the circuit if you've got big clots. And always consult with the perfusionist or the intensivist in conjunction with care. You've also got infection. Infection can be identified with positive blood cultures or an elevated white blood cell count. Or look at the site. The management involves monitoring for signs of infection, daily blood cultures depending on your organisational policy, consulting with an infection diseases specialist, providing prophylactic antibiotics, again according to your unit policy and your intensivist or the physician in charge. Line catheter changes, only as a last resort. They're not recommended because of the potential of hemorrhage and infection again. When it comes to neurology, some of the potential complications could be hypoxemia associated with seizures, interventricular hemorrhages, stroke, even brain death. The management: monitor blood pressure, the coagulation profile, and avoid hypoxemia, acidemia, hypercarbia, and utilise some sort of neurology tool such as the Glasgow Coma Scale. When it comes to the cardiovascular component, you can look at things like hypotension, hypertension, vasoconstriction, tachycardia, bradycardia. Management: monitoring closely and avoid hypertension, tachycardia, bradycardia, hypoxemia, and consider, if necessary, vasopressor support, which you already will have with your ECMO patient, such as epinephrine, norepinephrine, dopamine, dobutamine, and so on. Consider beta blockers, nitrates, angiotensin converting enzyme inhibitors, ACE, and possibly a change from V-V ECMO to VO ECMO in extreme situations. Cardiac potential complications could be tachycardia, cardiac dysrhythmias, cardiac arrhythmias, bradycardia, hypoxemia, electrolyte imbalances, cardiac stunning, and cardiac tamponade. Management: monitor closely. Avoid hypotension and hypotension. Avoid tachycardia and bradycardia. Avoid hypoxemia, electrolyte and acid-base derangements, and consider vasopressor support, antiarrhythmics, beta blockade, even sodium bicarbonate in extreme situations, and consider a change from VV to VA ECMO. Then you've got potential pulmonary complications such as intrathoracic, which could relate to barotrauma such as pneumothorax, pneumoperitoneum, subcutaneous emphysema, pneumopericardium. The list goes on. You monitor closely the daily chest x-ray, avoid ventilator-associated lung injuries, ventilator-induced lung injuries, and ensure that there is a low peak inspiratory pressure if possible, a low peak plateau, low FiO2 oxygen percentage, PEEP, tidal volume, and frequency of ventilation. In the event of renal insufficiency and failure, you monitor for oliguria, elevated creatinine levels, also urea, uric acid, I guess, also proteinuria and hematuria. The management, daily weight. Monitor intake and output stringently. Monitor creatinine and urea. Avoid diuretics if possible. They can cause hypotension. Avoid excessive fluid intake, overloading. Avoid hypoxemia. However, you may have to consider fluid intake reduction and limiting to 100 ml per kg per day, and you may have to think about diuretics if the patient is overloaded, and consider using continuous renal replacement therapy, of which there is Dr Manny Learnshops on continuous renal replacement therapy if you want to review, using Prismaflex and the Fresenius unit. Also remember, look at overloaded, hyperkalemic patients with refractory acidemia and azotemia, right heart failure. Then there are gastrointestinal problems which could involve gastritis, hemorrhage, melena and hematemesis. Consider in the management daily weight, their nutritional state, avoid fasting and starvation, avoid dehydration, consult with a dietitian. Also consider nasogastric tube, enteral feeding tube, feeding, proton pump inhibitors, histamine 2 blockade and enteral feeding. For those of you that are not familiar with certain medications, go to the Dr Manny Learnshops on pharmacology. They cover these simply and effectively. Then you've got metabolic complications or potential problems such as hypoglycemia, hyperglycemia, acidemia, acidosis, alkalemia, alkalosis, and hyperbilirubinemia, jaundice. Management is monitor their electrolytes, serum calcium, potassium, magnesium, phosphate. Also, look at their arterial blood gases. There's a Dr Manny Learnshop on arterial blood gas analysis, which is very, very simple and effective. Also, we want to monitor the venous blood gases if arterial blood gas stabbing is potentially problematic. Avoid hypoglycemia, hyperglycemia, acid-base derangements. Then we have potential system-related complications, and they include the cannula. The cannula is being inserted into the internal jugular, the femoral vein, close to the superior vena cava. If it's going in that direction, it can affect the SA node, the AV node, the tricuspid valve, and it can result in arrhythmias, thrombosis, recirculation, hemorrhage, which could be intrathoracic if you've now got insertion via the internal jugular or subclavian vein. There can be displacement, migration, or decannulation. You can also have air embolism, and this is when the cannula is outside the vessel through displacement or migration. Decannulation can occur, cavitation can also occur. Management, to monitor the vital signs, monitor the circuit, monitor the pre-saturation oxygenation, post-saturation oxygenation blood gases, check for security, leaks, bubbles, connection of the tubing integrity, the cannula to the tubing, and if it's appropriate, a daily chest x-ray or PRN according to your unit policy. Avoid or prevent kinking, acute neck positions, abnormal traction and cavitation. And it's important, no unauthorized connections and no use of alcohol-based products, as it can interfere with the integrity of the circuit. When it comes to the circuit and the tubing, it's polyvinyl chloride, and this can result in thrombosis, hemorrhage, displacement, disconnection, excess torsion, traction pulling, and rupture of the raceways, which however is typically related to the high pressure systems of the venous arterial ECMO circuit. But it could happen as well in the V-V ECMO circuit. Management: monitoring closely. Observe for leaks, bubbles, connection integrity. Avoid dependent loops, breaking the circuit, adding additional stopcocks or additions to the circuit. Avoid alcohol-based products. It can affect the integrity of the circuit. Then you've got the pump. The pump can fail as a result of AC failure. In the cardio help, you've got a battery life of 90 minutes. It can also result in mechanical failure. All pumps can. It's a machine. When it comes to the management, you can monitor if the AC power is connected on most devices. It informs you on an LED. It informs you whether the battery is charging. And in most, there's an emergency crank or drive that can be utilised to provide manual power until you can disconnect the patient or use the bridge. Here's the bridge and bladder. The bridge is clamped and ready. The bladder box is functioning and clot-free. The management: you monitor the bladder box, you monitor for increasing negative pressures, you monitor for thrombosis that could be forming. You make sure that the clamp is always on the bridge and you avoid clots in the bridge and the bladder. If possible, they can be aspirated. Then we have the gas blender. Make sure oxygen is connected and at the correct flow rate as ordered. The gas exchanger or oxygenator can malfunction. Thrombosis and air can be visible. There may be no change in the pre or post saturation for the oxygenator, indicating a problem. The pre and post pressures, the transmembrane pressures, can be increasing or very, very high, greater than 60 millimeters of mercury, indicating a problem. There can be a potential for air embolism, which can be reflected in a PaO2 of greater than 600 millimeters of mercury, because again, you have a problem in related to saturation or cavitation, or there could be a tear in the gas exchanger membrane, which however is typically related to veno-arterial ECMO, not typically veno-venous ECMO. Then you've got the heat exchanger. You observe for the correct temperature set, not the incorrect. This could result as a result of malfunction. The patient's core temperature could be abnormal, or it could be abnormal reflecting hypothermia and hypothermia. The management: escalate to the intensivist, the perfusionist, the bioengineer, your immediate supervisor. Always escalate if you have a problem or you think that there's a problem. Better to err on the side of caution. Now, when it comes to the Hemo Filter or continuous renal replacement therapy, the cannula, you can have thrombosis and hemorrhage occurring, displacement or disconnection. The tubing, there can be excess torsion or traction or pulling. The filter, pressures can be wrong, incorrect. They can be increasing. The transmembrane pressure, pre and post, can be increasing, greater than 100 millimeters of mercury. Or the filter drop pressure could be high. If you're not familiar with CRRT, as I mentioned previously, have a look at CRRT with the Dr Manny Learnshops. They provide you a lot of information that is fairly simple and straightforward to follow. Using the Prismaflex or the Fresenius unit. The management: check the position of the cannula, the patient, the tubing, the filter for clotting, the blood flow rate, the heparin infusion, and consider returning the patient's blood and changing the circuit if required. Monitoring equipment may also fail. If you have any of these problems, you always escalate management issues to the perfusionist, intensivist, bioengineer. Never be silent. Speak up. It's better to err on the side of caution than have an emergency situation. Thanks again. If you found this of any benefit, please escalate it to your colleagues. Subscribe if you choose to, and follow through with Veno-Venous ECMO Part 7, 8 and 9 on YouTube. See you again.